So good morning and welcome everyone to the Genitourinary Cancer panel. My name is Vivek Narayan from the University of Pennsylvania, and we're joined by a really wonderful panel today. And maybe we'll start by just first introducing each of us. So we can first start with Hala Borno from University of California.
Hi, I'm Hala Borno. I'm an assistant professor of medicine at the University of California, and I'm a genitourinary medical oncologist with expertise in the treatment of advanced prostate cancer. Thanks for having me.
And we'll go to Dr. Stephen Chang as well.
Hi, I'm Dr. Stephen Chang. I'm a urologic oncologist at Dana-Farber Cancer Institute and Brigham Women's Hospital. It's a great pleasure to be here this morning, and thanks so much.
Great. And finally, we have the pleasure of having a patient advocate join us as well. So Salima, can you introduce yourself?
Hi guys, my name's Salima Witt. I'm a stage 3 kidney cancer survivor, currently in remission over 2 years here in San Diego. Thank you for having me.
Great, well, wonderful. So we have a great discussion planned for today where we're going to hit some of the highlights of genitourinary cancers over the past year, and then also focus some attention on how COVID-19 and the pandemic has transformed some of the clinical care for these GU cancer malignancies. So I'm going to start things off, and I'm an assistant professor of medicine at the University of Pennsylvania Abramson Cancer Center, also a GU medical oncologist, and I was asked to provide updates from 2020 on urothelial cancers and renal cell carcinoma. And I thought I would structure this by just focusing on 2 primary clinical questions from this past year. So first, can we potentially improve clinical outcomes with the earlier introduction of immunotherapy in urothelial cancer? And second, can we potentially confirm long-term efficacy of immunotherapy and TKI combination therapy strategies in advanced renal cell carcinoma? So I thought I would start first with urothelial cancer, and first this question of whether we can improve clinical outcomes with the earlier use of immunotherapies. And when we look at the systemic therapy landscape for urothelial cancer, we know that the fundamental systemic therapy remains platinum-based chemotherapy. And this can either be given as a neoadjuvant cisplatin-based approach for muscle-invasive bladder cancers, or as various combination platinum-based regimens for the first-line treatment of metastatic disease. More recently, we've also seen the advent of immunotherapies with immune checkpoint inhibitors, primarily in the post-platinum metastatic setting based on a variety of phase 3 trials, but also more recently with pembrolizumab in the non-muscle invasive bladder cancer setting. And so 2 remaining questions when looking at this systemic therapy landscape are first, whether a potential switch maintenance strategy with immunotherapy in the first-line metastatic setting could have a role. And second, whether there may be a place for adjuvant therapy with immunotherapy in those patients with resected muscle-invasive bladder cancers. So to address one of these questions this past year, we saw results of the Javelin Bladder 100 study. And this was a randomized phase 3 clinical trial that took a population of patients who had a complete remission, partial remission, or stable disease following standard first-line platinum-based chemotherapy. And importantly, this could either be cisplatin or carboplatin plus gemcitabine. And following an initial 4 to 6 treatment cycles, patients were randomized either to the standard of best supportive care and observation alone, or to switch maintenance with the anti-PD-L1 immunotherapy avelumab given intravenously every 2 weeks. And here the primary endpoint was overall survival. And just to highlight a few things when looking at the baseline patient characteristics, I'll just point out that about 50% of patients had visceral metastatic disease, which we know is a negative prognostic indicator in this population. About half of patients had cisplatin-based frontline chemotherapy, and about 70% of patients had either a complete response or a partial response as their best initial response to first-line chemotherapy. And when looking at the primary endpoint of overall survival in the intent to treat overall study population, this was clearly in favor of the immunotherapy treatment arm, with a median improvement in overall survival that was highly statistically significant. And this translated to about a 13% absolute improvement at 1 year, and about a 17% absolute improvement at 18 months following randomization. In addition, for a secondary endpoint of progression-free survival, by an independent radiology review committee, again in the overall study population, this also favored the intervention arm of avelumab therapy, where the difference was statistically significant and corresponded to about a 17% absolute improvement in PFS at 1 year. So the question that comes from this is this large randomized phase 3 trial potentially practice changing given this positive result? And my own feeling is yes, it is, but with one important caveat, and that is that this particular study design does not directly compare the switch maintenance avelumab strategy with what is more currently done, which is the use of a second-line immunotherapy at the time of progressive disease in those patients who have already received frontline platinum-based chemotherapy. And that's largely owing to the study design, which didn't permit or allow specified crossover to the intervention arm for those patients progressing. But I think what's also important to note is that metastatic urothelial cancer is generally a patient population that has a lot of medical comorbidities, and it reflects a very aggressive disease. And in fact, in clinical practice, many patients may not ultimately make it to an effective and meaningful second-line immunotherapy strategy. And in fact, when looking at the subgroup of patients who had progressive disease on the control arm of this study, although about 3/4 of patients went on to receive some subsequent anti-cancer therapy, only about half of patients went on to receive a second-line immunotherapy. And so when looking at, again, the systemic therapy landscape for urothelial cancer, I think it is fair to say that switch maintenance with an immune checkpoint inhibitor does represent a new standard of care for these patients following initial platinum-based chemotherapy. But what about this second role, so potentially adjuvant therapy for resected muscle-invasive bladder cancer? Could immune therapy potentially have a role there? And so there we saw the results of a phase 3 trial called the IMvigor10 study. And this was again a randomized clinical trial that took a population of patients who had high-risk muscle-invasive urothelial cancer. So this was either bladder urothelial cancers or upper tract disease. And it was a relatively high-risk patient population, or those patients with adverse pathology at the time of cystectomy. And patients were randomized either to the standard of clinical observation or to the anti-PD-L1 immunotherapy atezolizumab administered every 3 weeks for up to 1 year. And here the primary endpoint was disease-free survival with a key secondary endpoint of overall survival. Again, looking at the baseline patient characteristics, I'll just highlight that about half of patients had prior neoadjuvant chemotherapy. So this is generally platinum-based therapy prior to surgery. And again, this reflects a very high-risk patient population where about 50% of patients had pathologic node-involved disease at the time of surgery. But when looking at the primary endpoint of disease-free survival in the intent-to-treat population, there was unfortunately no difference between the treatment arms, and so this was overall a negative study. This was additionally confirmed in subgroup analyses looking at the biomarker of PD-L1 expression, where there was no statistical difference between the two treatment arms in either the PD-L1 negative population shown on the left or in the PD-L1 high population shown on the right. And so we can say that at least at this point, there's no clear role for adjuvant immunotherapy for those patients with high-risk muscle-invasive bladder cancer following surgery. So now turning to renal cell carcinoma and the second clinical question of whether we can confirm long-term efficacy of a combination of immune therapy and TKI therapies for metastatic disease. And when looking at the treatment landscape for metastatic renal cell carcinoma, we know that there's been a variety of drug approvals over the last decade and a half, but largely in the last several years, we know that combination immunotherapy-based strategies reflect the current standard of care for most frontline patients. And this is largely based on the Checkmate 214 study, which led to the regulatory approval of ipilimumab plus nivolumab for those patients with intermediate or high risk or intermediate or poor risk advanced RCC. And also more recently with the Keynote 426 study, which led to the approval of the combination of the TKI axitinib plus pembrolizumab in a more all-comer risk agnostic patient population. But one caveat with the Keynote 426 study is that this was based on an initial minimum of 7 months clinical follow-up at the time of its initial study presentation. And so this past year, we were able to see updated results with longer-term follow-up of this Keynote 426 study, now with a minimum of 23 months follow-up, to assess the longer-term efficacy of this combination strategy. And so as a reminder, the Keynote 426 study took patients with newly diagnosed or recurrent stage 4 clear cell renal cell carcinoma, all of whom were treatment naive, and randomized them to the former standard of care sunitinib TKI therapy given at standard dosing, or to the novel combination of pembrolizumab immune therapy plus the axitinib TKI. And the dual primary endpoints were overall survival and progression-free survival. And here, one notable point is that at this point in study follow-up, approximately half of the patients on the sunitinib control arm have gone on to receive some form of anti-PD-1 or anti-PD-L1 immune therapy as a subsequent therapy following progression on the sunitinib TKI arm. And what we saw with this longer-term follow-up is that this overall survival benefit in the intent to treat population appeared to be strongly confirmed in favor of the combination treatment arm. So again, looking at the Kaplan-Meier curves at about 1 year, there was a clear benefit in favor of the combination treatment arm, and this translated to about an 18% absolute survival improvement at 2 years, again, highly significant. This was reflected in the confirmed objective response rates between the two treatment arms, where it was around 60% for those patients receiving combination therapy and about 40% in those patients receiving sunitinib alone. And importantly, this reflected about 9% of patients who had a complete response, only about 11% or approximately 1 in 10 patients who had primary progressive disease on therapy, and the median duration of responses approached 2 years. One notable point is that there still does appear to be a prognostic risk group difference in the overall clinical outcomes. So if we look at those patients who have IMDC intermediate or poor risk and look at the clinical outcomes of overall survival, progression-free survival, and response rate, it's clear that this strongly favors the combination treatment arm in all 3 clinical categories, where there's clear benefit in favor of pembrolizumab and axitinib. However, when looking at the favorable risk subgroup of patients, looking at the overall survival outcome, it is notable that with this longer-term follow-up, there's not a clear difference between the 2 treatment arms, likely reflecting that patients with favorable risk disease appear to do well irrespective of what treatment we give them in the frontline setting. Although notably, there does still appear to be a benefit with combination therapy in terms of both progression-free survival and overall response rate. And so when I look at the current management options for metastatic clear cell carcinoma, renal cell carcinoma in the frontline setting, I think it's fair to say that a combination immunotherapy-based approach remains the recommended first-line strategy for the majority of patients with advanced RCC. And this could either be ipilimumab plus nivolumab for those patients with intermediate or poor risk disease, or a TKI-IO combination for those with good, intermediate, or poor risk disease. But I'll just highlight that alternate first-line options are still there and reasonable for some patients, and especially for those patients with favorable risk disease, where depending on the overall burden of metastatic disease and the patient toxicity risk profile, it's reasonable in many cases to still use a VEGF TKI alone, or perhaps even close active surveillance in those patients with indolently progressing asymptomatic disease. So with that, I'll just again reiterate the final takeaways from my view on renal and urothelial cancers over this past year. I think the practice-changing finding is the now approval and use of switch maintenance with avelumab immune checkpoint inhibition, which has been shown to improve overall survival in metastatic urothelial cancer following platinum chemotherapy. And I think a more practice-affirming study is that we now see longer-term follow-up, that immunotherapy combinations remain standard frontline treatment for all patients with metastatic RCC. So I will stop there, and certainly happy to open them up to discussion before we move on to the next segment. So I don't know if the other physicians, or certainly Salima from the patient perspective, if there are other thoughts or questions about this.
Well, for me, I mean, not being a physician, it's amazing to me all the combinations of treatments that are constantly being made, and it's just wow. I'm looking at these charts, and it's amazing to me and looks very hopeful for patients like myself.
Yeah, I think that's a really fair point. And, I think from a provider's perspective, what is now becoming a challenge is, in a good way, is that we have so many of these various combination strategies that appear to be effective in certain patient populations. And the challenge from a provider standpoint now is, how do you choose the optimal potential combination for an individual patient who you might be treating? And it's in some ways almost an embarrassment of riches when you have these various combinations that have all shown pretty compelling clinical results. But one key piece that's missing is we don't have a lot of head-to-head comparative data between these combination strategies. So it's hard to tell a particular patient with a high level of confidence that one combination strategy is clearly the most efficacious for them. And really it becomes sort of thinking about the various toxicity profiles, your willingness to tolerate potentially primary progressive disease, but potentially to gain some longer term advantage, and really patient preference about, how willing they are to tolerate potential immune related side effects versus TKI side effects, and so on. So it is a challenge, but I think a good one to have. And hopefully in the coming years, we'll have better clarity on which of these regimens makes the most sense for which patient.
Yeah, even 5 years ago, what you're doing differently now, and what it'll be like you say, in 5 years from now. It'll be amazing.
And I think a similar phenomenon is really happening in urothelial cancer as well, where 5 years ago it was really platinum-based chemotherapy, and then unfortunately not a whole lot else. And that has really changed in the last several years, where not only with immune therapies, but now multiple other agents which have gained FDA approval for advanced urothelial cancers. So whether it's enfortumab vedotin, which is an antibody drug conjugate, which is now widely used, and or novel targeted therapies that target the FGFR receptor. So we really do have a lot of new agents, and really the next question is, how do we sequence these agents? Which do we use in which patients and at what time? And I think those are the imperative questions that people are trying to address now.
Wow. Thank you, Doctor.
Okay, so maybe we'll transition then over to Dr. Borno, who's going to talk to us about remote and virtual care data, especially in the setting of COVID-19, and then also reflect on some prostate cancer updates over the past year.
So thank you for that, Dr. Narayan. Today I'll talk to you about remote and virtual care data in prostate cancer updates. So first, as we talk about cancer treatment, we absolutely need to address the current environment and context in which we're practicing. And that's the context of the COVID-19 pandemic, where we have observed multiple changes in practice patterns and the availability of certain treatments. So in the context of the pandemic, when we look at data reported by Flatiron Health, which has a proprietary electronic medical record system, we can observe that there was initially a marked decline in the availability of new patient visits for patients with a cancer diagnosis. When we look at other, we also observed that there was increase in patient cancellations of visits and provider cancellation of visits. And this was observed across the United States with pretty consistent changes across all regions in the United States. On the left, you can see that there was a decrease in chemotherapy and non-chemotherapy patient visits by region. And on the right, you can see that there was an increase in patient cancellations and no-shows. As a result of these pretty stark changes, there was also change in the delivery of healthcare and the use of virtual care. And what we observed, and this is a data reported out from the University of California, San Francisco, that there was a marked and fast rise in utilization of video and telephone encounters in order to deliver cancer treatment rapidly in the context of shelter-in-place policies during the COVID-19 pandemic. And so this demonstrates that in the time of crisis, that there can be a major shift in the way that patients experience cancer treatment. When gathering patient perspective with these changes, we did a small survey study at the University of California, San Francisco, and asked patients if they were impacted by COVID-19 as it relates to cancer treatment, and about 32% said yes. When asked if they were concerned about the pandemic leading to a worsening of their care, again, 30% of patients said yes. Digging deeper, we asked if, since the start of the COVID-19 pandemic, have you avoided telling your doctor about symptoms you're having? A small subset of patients said yes at 4.6%. Avoided going to a pharmacy to receive medications you need. A small subset of patients said yes at 17.6%, and then delayed or avoided seeking care, 21.3% of patients said yes. The key conclusions from these data is that there's a really marked shift in the ways that patients are seeking healthcare in the context of the COVID-19 pandemic. The COVID-19 pandemic did decrease the availability of new patient visits and increase the utilization of virtual medicine. And the next question that is left unanswered is, are these changes towards virtual medicine going to stick around after the end of the COVID-19 pandemic? And that is still to be seen. So with that, I'd like to shift gears a little bit to prostate cancer updates. And I'm going to discuss 3 different types of works in 3 different disease states. So first, I'll talk about the HERO study, which is in the earlier disease state, hormone-sensitive disease state. Then I'll give an updated survival data for non-metastatic castration-resistant prostate cancer settings, the Aramis, Prosper, and Spartan studies. And then I'll close looking at data for the metastatic castration-resistant prostate cancer population, reporting on the PROfound study. So HERO was a phase 3 study. It was a multinational randomized open label parallel group study to evaluate the safety and efficacy of Relugolix in men with advanced prostate cancer. The primary endpoint for this clinical trial was sustained castration through 48 weeks, which they define as a serum testosterone level of less than 50 nanograms per deciliter. The patients that were enrolled into this study were classified as having advanced prostate cancer, and they were randomized in a 2-to-1 fashion to either Relugolix oral tablets, which entail a 360 milligram loading oral dose on day 1, followed by 120 milligram or oral dose daily, versus standard of care of leuprolide acetate dosed at 22.5 milligrams, which are quarterly injections, or 11.25 milligrams in Japan and Taiwan. Patients' primary endpoint was evaluated at week 48, as well as some key secondary endpoints, and testosterone recovery was followed in this patient population. I highlight here the clinical characteristics because, as you probably noted, it included patients with advanced disease, and this could include either biochemical relapse, which is just a rise in the PSA after definitive treatment, versus newly diagnosed androgen-sensitive metastatic disease, or advanced localized disease. So there was some heterogeneity in terms of the types of patient clinical characteristics that were recruited to this clinical trial. But what you can see here is across treatment arms, there was balance for these different characteristics. Now, the primary endpoint of sustained castration was met for this clinical trial, and Relugolix achieved a 96.7 response rate, and the threshold to achieve the primary endpoint was 90%. Leuprolide achieved an 88.8% response rate. When we look at time course of testosterone suppression and then testosterone recovery, which was a sub-study, you can see here that Relugolix achieves a pretty rapid decline in serum testosterone levels. It does not entail this transient testosterone flare that you can see with leuprolide by virtue of being an antagonist compared to leuprolide, which is an agonist. And then when you look at the testosterone recovery period, you can observe that there is a much rapid recovery in serum testosterone compared to leuprolide. Now, what about adverse events and safety? When you observe overall for any adverse events, Rulagolex and Leuprolide have comparable levels at 92.5 versus 93.5. When you look at adverse events reported for greater than 10% of patients in any treatment arm, the key symptoms that I'd like to bring your attention to are diarrhea, which is reported at 12.2% in the Rulagolex population, as well as arthralgia, which is also higher at 12.1%. Now, this is a finding that I'd like to call your attention to, which is cardiovascular adverse events, and looking at Rulagolex compared to Leuprolide. Now, they tracked major adverse cardiovascular events, also known as MACE. And what you can see is that 2.9% of patients receiving Rulagolex had a major adverse cardiovascular event compared to 6.2%. Now, when they stratify based on history of a major adverse cardiovascular event, you can see a striking difference where the Rulagolex percentage is 3.6 and Leuprolide is 17.8 with an odds ratio of 15.8. Here you see that there's a 54% reduction in risk of major adverse cardiovascular events for patients who are on Rulagolex compared to patients who are receiving Leuprolide as their form of androgen deprivation therapy. So the key conclusions here is that the primary endpoint was achieved and 96.7% achieved and sustained castration through week 48. Rulagolex achieved superiority over Leuprolide with sustained castration rates, and castration and profound castration was achieved by day 15, and PSA response was also achieved by day 15. Testosterone recovery within normal range was achieved at 54 versus 3% with the Leuprolide arm at 90 days. So Rulagolex once daily oral therapy is well tolerated, and the striking observation is that the risk of major adverse cardiovascular events was 54% lower with the Rulagolex than Leuprolide treatment arm. Now I'd like to shift gears to a more advanced disease state, which is castration resistance. Now I'll be talking about 3 clinical trials which report effectiveness of oral therapies in the non-metastatic castration-resistant prostate cancer setting. These clinical trials had similar eligibility criteria, which is including non-metastatic castration-resistant disease, baseline PSA greater than 2 nanograms per milliliter versus a rising PSA despite castrate levels of testosterone. So that is castration and a baseline level also here in the Prosper arm being greater than 2 nanograms per deciliter. All studies required that the PSA doubling time was less than or equal to 10 months. And what you can see here when you look at Spartan, which evaluated apalutamide versus placebo, and Prosper, which evaluated enzalutamide versus placebo, and Aramis, which evaluated darolutamide versus placebo, that these studies all evaluated metastases-free survival as the primary endpoint. When you look at this primary endpoint, you observe that all of them achieved a significant finding, which is Spartan observed a 72% reduction of distant progression or death. A median MFS of apalutamide was 40.5 months versus placebo is 16.2 months, the 24-month metastases-free survival benefit. Prosper showed a 71% reduction of distant progression or death. Median MFS of enzalutamide was 36.6 versus 14.7 months with placebo with a 22-month MFS benefit. Aramis showed a 59% reduction of distant progression or death with a median MFS of darolutamide of 40.4 versus placebo of 18.4 months with a 22-month metastases-free survival benefit. Here you see the updated overall survival data, Spartan showing a 22% reduction of risk of death, Prosper 27% reduction in risk of death, and Aramis showing a 31% reduction in risk of death. So here's a scenario where we have 3 oral therapies FDA approved for the same indication. How do you think about these treatments, and how do you think about the toxicities associated with these treatments? I showed these in comparison, but it must be noted that the safety monitoring involved with these clinical trials were distinct. And specifically, Spartan did involve monthly AE reporting, whereas Prosper and Aramis reported every 16-week adverse event or AE reporting. So as you can see here, the adverse event percentage was higher for the Spartan study compared to the other two clinical trials. When you look at the different toxicities, I'll call your attention to fatigue, which seems to be higher for Spartan and Prosper compared to Aramis, the darolutamide drug. And then when you look at falls, it's reportedly higher in apalutamide and enzalutamide compared to darolutamide. And fractures as well as highest in the apalutamide, not reached in the Prosper clinical trial, and 4.2% in darolutamide. So the key conclusions is treatment of patients with non-metastatic castration-resistant prostate cancer was associated with prolonged MFS and overall survival, despite a large majority of men receiving subsequent treatment, and early intensification of treatment appears to benefit patients. Now I'd like to shift gears to the PROfound clinical trial, which included patients with metastatic castration-resistant prostate cancer. The key eligibility criteria were men with mCRPC with disease progression on prior therapy with abiraterone or enzalutamide, and alteration in one or more of any qualifying genes with a direct or indirect role in homologous recombination repair. Key stratification variables were receipt of prior taxane or measurable disease. Patients were randomized in a 2-to-1 fashion for this clinical trial. There was cohort A, which included patients with a BRCA1, BRCA2, or ATM gene, or cohort B, which included other alterations. Patients were randomized either to olaparib, 300 milligrams twice daily, or the control. And upon progression, the control patients were allowed to cross over to olaparib. Patients in the control arm had the option to cross over to olaparib if they met the following criteria: radiographic disease progression, no other subsequent anti-cancer therapy, any toxicity from prior therapy grade less than or equal to 1, and agreement to continue with the study visit. 66% crossed over to the olaparib treatment arm. The pre-specified sensitivity analysis of overall survival, adjusting for the impact of patients in the control arm receiving subsequent olaparib treatment, was conducted. Here, what you can see is that the overall survival for patients who were on olaparib compared to the control arm was higher. That the median overall survival was 19.1 months compared to 14.7 months, with a hazard ratio of 0.69 and a 95% confidence interval of 0.50 to 0.97. When you look at cohort A with an adjustment for crossover, you can see that the difference in overall survival is even more striking. Now, when you look at the data when it was genomically stratified, you can see that not all genes are created equal in terms of response, and among cohort A, the gene with the highest response was patients who had the BRCA1 alteration, followed by BRCA2, and then by ATM. So key conclusions for this study is that olaparib improves overall survival among patients with metastatic castration-resistant prostate cancer and homologous recombination repair genes. The largest benefit is observed in patients with BRCA1 or BRCA2 alterations. So I'd like to stop there and see if there are any questions from my colleagues or from our patient advocate.
That's really great, Dr. Borno. I think one nice point that I think you made was regarding the relugolix GnRH antagonist therapy and sort of the striking difference in adverse cardiovascular events between the two treatment arms. And it seems that there's a building story of potential cardioprotective advantage with GnRH antagonist therapies over the last few years. And so although the underlying mechanisms for that still remain a little bit unclear. And so, assuming that we get approval of relugolix in the coming months to year, is that a therapy that you would consider for patients with underlying cardiovascular risk and prostate cancer needing ADT?
That's a great question, Dr. Narayan. And I think that's exactly right, that now we have a tool in our toolkit to consider perhaps for our patients who qualify as having MACE or a major adverse cardiovascular event. I would say the odds ratio difference for the treatment arms is quite striking. And if we do have a tool that we think a patient can use, mind you, this is a daily oral therapy, which can be challenging for some patients to adhere when you're comparing it to a quarterly injection, then I think it's worth considering. But I think there needs to be the promise for adherence in order to ensure sustained castration. And that may be a complicated promise for patients who are qualifying as having a major adverse cardiovascular event. Having said that, I do think it's worthwhile to consider. I think the other piece to consider for this drug is, of course, the time to testosterone recovery is much more rapid. And as we practice the standard of care for non-metastatic hormone-sensitive prostate cancer, which is intermittent androgen deprivation therapy, where patients cycle in and out of androgen deprivation therapy, there may be a hunger for a more rapid rise of their testosterone once they're off the androgen deprivation therapy. And so I think that it may be a tool in that scenario as well, in order to give patients more quality of life and a recovery in their testosterone when they're cycling in and out of intermittent hormones.
Yeah, I think that's a great point. Just from a patient perspective, certainly offering some advantage in regaining the gonadal function in a more rapid manner.
Absolutely.
For me, I can comment, or if you don't mind, the beginning of your presentation, and thank you, Doctor, regarding COVID-19 and its effects on treatment. I was going in for my checkup, my remission checkup at the beginning of March, right when the pandemic hit. And I absolutely can say that I was one of those people that took a moment to think about going in to do the CAT scan, to think about, it was so frightening at the time. We didn't know what we were dealing with. Currently now, I'm due for another one next month, and I don't have an issue at all going in, and I plan on keeping all my appointments, but I absolutely see how COVID has played a role in giving a lot of anxiety, a lot of trepidation, and going into the hospital. But for me personally, I felt that the cancer checkup was extremely important. I needed to go, but it did enter my mind not to. It did, for sure.
I appreciate you sharing that perspective. I think it's critical for us to think about patient concern and fear about our current environment and the risks that they pose and the feelings of vulnerability. COVID-19 certainly makes us all feel vulnerable, but that's overlaid on patients who have, prior treatments, may be immunocompromised, may require multiple visits that introduce a higher risk of exposure in certain contexts, depending on the COVID-19 disease burden. We absolutely need to acknowledge that fear and create a plan that makes patients feel that they can safely continue, their treatment or surveillance while also not being at an unnecessary risk to the virus.
I must say that I'm also in the UC system. My treatment was done and is done here at the UCSD facility. And I must say that they've implemented a lot of stepping stones to help us with that anxiety and moving forward. I'm absolutely fine with video visits and all that they've implemented with COVID. So far, no problem from the patient perspective as far as me, not at all.
That's great to hear.
All right, well, I think that then we can shift gears and move to the final presentation. I will go ahead and share my screen. So I am Dr. Stephen Chang. I'm one of the urologic oncologists at Dana-Farber Cancer Institute and Brigham Women's Hospital. I've been tasked to speak about delays in care, which I'm going to be calling surgery in the time of COVID. This is a distinctly different talk than the two prior talks that you've heard about. And I'm going to start off by showing a screenshot of something that I think most of the audience has seen before. This is a New York Times figure for new cases in the United States for our current COVID-19 pandemic. Early on in mid-March, we here in Massachusetts, I'm certain in many other states, received a message of this from our governor. It was that all non-urgent elective surgeries must be canceled effective March 16th. Again, I think most other states had something similar. And of course, this is quite reasonable with the expected influx of patients coming in. But I think the question is, what is considered non-urgent elective? You know, we're doing most of this in order to free up hospital resources, but of course, we're also dealing with cancers. And I would say that genital urinary cancers are relatively unique. You know, we have a substantial variation in the management of these tumors or cancers. We have a great deal of multidisciplinary care. And of course, at least in geo-oncology, there is a predominance of patients who are older. So we're actually commonly used to triaging patients. For example, for many of our diseases, some cancers can be rapidly progressive and surgery can be curative. For those, of course, we would want to proceed directly to surgery. On the other hand, there are many cancers that could be indolent or non-lethal, and there may also be very effective alternatives to surgery. But now with this pandemic, we are dealing with the elevated surgical risks associated with COVID-19. And so beyond just freeing up hospital resources, we're deferring surgery in order to avoid some of these potential added risks. And what are some of these risks? This is, of course, an area that hasn't been thoroughly studied, but one of the most commonly cited papers was one that came out relatively early in the Lancet. 235 hospitals in 24 countries looked at over 1,000 patients who underwent surgery with COVID-19, most of whom had received emergency surgery, but about a quarter of which underwent an elective procedure. But the results are fairly striking. About half of patients, both in the emergency surgery and elective surgery arms, about half of patients had some form of pulmonary complication following surgery. Probably what is more concerning is that among those undergoing an emergency surgical procedure, about a quarter of patients died, and about 1 in 5 died with an elective procedure. So there is substantial morbidity and mortality associated with undergoing surgery if you have COVID-19. On top of that, there is the concern for nosocomial or nosocomial COVID-19 infections. So these are hospital-acquired infections. For example, with surgery, if the endotracheal intubation is considered an aerosol-generating procedure, so when the tube is placed within the throat of a patient at the beginning of surgery, it's at that time that there can be spread of COVID-19. And much of this is extrapolated actually from the prior SARS epidemic. Back in 2012, this paper identified patients with that form of coronavirus and intubation as having an odds ratio of 6.6 for the transmission of that infection. Basically, there was an absolute increase in about 10 or 15% for transmission of that coronavirus. But for the current coronavirus, SARS-CoV-2, it's well recognized that there is a high viral load within the sputum and upper respiratory secretions. And thus, it does make perfect sense that intubation and extubation are viewed as high-risk procedures. As you can imagine, there have been a multitude of different and more stringent protocols for that period of surgery. Also, there are some procedures that seem to be more potentially challenging or dangerous, rather. Minimally invasive surgery is hypothesized to be at a higher risk for spreading COVID-19 than open surgery. And it's based on a couple of reports, and so the general consensus is that this is an area of concern, but definite evidence is lacking. But overall, there is a propensity to perform an open procedure over a laparoscopic or minimally invasive procedure, all things being equal, to minimize the chance for spread of COVID-19. So going back to that early period in March, you know, many of us were faced with thinking about what do we do with our patients who are scheduled for surgery. For some of these surgeries, it was very obvious. We should just defer the surgery. There's no impending doom for these patients, no imminent danger. Other ones, in contrast, we would definitely have to proceed with. But there were many patients that sort of fell into the middle, maybe, depending on the situation. And there have been actually a lot of studies in the medical literature now looking at how different institutions manage this. I'm just planning on sharing with you what we did here at our institution at Dana-Farber and Brigham Women's Hospital. And this is for the more common genital urinary cancers. So as you can imagine, for prostate cancer, low and intermediate risk, particularly those with favorable intermediate risk, we were recommending that all patients defer surgery, either just waiting until a later date for surgery, or considering shifting their care over to radiation therapy plus or minus androgen deprivation therapy. The bigger challenge was for patients with high-risk disease. Some of my colleagues felt strongly that they should proceed with a radical prostatectomy. Others felt very strongly that giving androgen deprivation therapy should be able to tie these patients over, if you will. So these were patients who we did have some debate about. But the ones that we actually proceeded without question were those who were a high-risk patient on a clinical trial. We have a good number of patients who are on clinical trials here at Dana-Farber Cancer Institute, and I'm certain at other major medical centers as well. And if they were on these trials, we would actually continue with their procedure. For kidney cancer or kidney tumors, for clinical stage 1 disease, there was a uniform consensus to defer surgery among these patients. And as we know, we have alternatives to surgery. Active surveillance is well recognized for the small renal masses, but thermal ablation, and in some centers like ours, we also have stereotactic body radiation therapy for kidney cancer. The more challenging scenario was for clinical stage 2. I felt pretty strongly that we could defer most of these cases, and but some of them, on a case-by-case basis, we would proceed with. But this turns out to be a pretty small group of our patients. Anyone who has a tumor that's in the stage 2 category, many of them are hard to distinguish from clinical stage 3, which is a tumor which may be invading the perinephric fat or the renal sinus fat or invading the renal vein and inferior vena cava. And these were patients who we felt should proceed directly to surgery. Now, for patients who would otherwise be considered for a cytoreductive nephrectomy, those patients were all being shifted to systemic therapy with a plan for potential consolidated surgery following treatment with systemic therapy. Shifting over to urothelial carcinoma, for tumors in the upper tract urothelial carcinoma that were deemed to be low risk, and that would be patients who had unifocal disease less than 2 centimeters in size, low-grade histology, and certainly no concern for invasion. We were also deferring these surgeries, many of which would have been a kidney sparing approach regardless. But if they fell into the high risk category, which is really all other patients, then we were proceeding with a nephroureterectomy. For urothelial carcinoma of the bladder, our low risk patients and those with high risk but non-muscle invasive, we were spacing out their cystoscopies and pushing more intravesical therapies rather than going to the operating room. But the cystoscopy or the surveillance was still being performed, just albeit at a lower frequency. Among patients with muscle invasive disease, we were also proceeding with surgery unchanged, and neoadjuvant chemotherapy plus radiation or radical cystectomy was continuing as previously scheduled. Certainly anyone with metastatic disease was proceeding to systemic therapy. And then among our patients with a testicular mass and testis cancer, both of these types of surgeries, the radical orchiectomy and the RPLND, were also proceeding as planned. So in summary, we were deferring surgery for many patients, but proceeding with a radical prostatectomy, specifically those with high-risk disease on a clinical trial, radical nephrectomy, most commonly for stage 3 disease, radical nephroureterectomy for high-risk upper tract urothelial carcinoma, radical cystectomy for muscle invasive bladder cancer, and either an orchiectomy and RPLND for patients with testis cancer. And going back to those patients who were in a more debatable situation, we looked at patient factors, surgical factors, and of course, hospital factors. And bringing all these together, the clinical judgment and shared decision-making, both among the surgeons, the administrators, the patients, and even in some cases involving an ethics committee input was necessary. I'm certain that this was being done all throughout the country, but also highlight that there are some groups that have tried to quantify these different factors into a more numeric metric to help decide who should and should not proceed with surgery. Now, between the mid-March period and probably about 2 months thereafter, there was really a minimal number of cases, but I'm proud to say that as we deferred the patients who could be deferred, we still continued caring for the patients who needed to have more urgent surgery. And during that later phase in the mid-May period, we instituted changes that allowed for us to restore surgical services. COVID-19 testing was mandatory. In fact, 2 negative tests, typically for all patients prior to surgery. And there was even some pockets of having routine testing for our surgical staff. By this point, our adequate PPE supplies were in place. We had more folks coming in available to staff the operating rooms. And a big issue there was making sure that our staff was not burnt out and the mental well-being was actually in place. And then making sure that our institutional resources were available in order to restore surgical services. Here at our institution, we had a priority tier to really cover our backlog of cases, and many institutions probably did things similarly. But by midsummer, one could argue that we were pretty much back to normal operations and have been since that time, despite how this figure looks with the rising case count. But looking at across, it wasn't a unique thing for my institution or even the United States. Looking at this one study that looked at urological services throughout the world, the darker the green, the more things were cut back. You can see it, there was a significant decrease in urological services in the United States, but it's not unique. South America and areas within the Middle East and Europe also saw a great deal of decrease in surgery. And I'd like to say that the story is somehow over, but we all know that this is an ongoing issue. Telemedicine is a problem, not just the actual performance of the telemedicine, but it's pretty common now that I won't actually see my patient in person until the actual day of surgery. There can be certain things that are missed, a patient's performance status, or frankly, their body habitus may be harder to recognize on telemedicine. We continue to have some issues with surgical training, with changes in the protocols of who can be in the operating room and certainly the types of surgeries that we're doing. And as something that was alluded to before in our discussion, patient concerns remain highly prevalent. And sometimes for patients who we need to do surgery, they really don't feel comfortable coming into the hospital. So we're still having some ongoing surgical challenges, though. I think the biggest question that most people have when thinking about the concept of delaying surgical care is, what was the clinical impact of this delay on the outcomes for these patients with GU cancers? Sadly, it's not clear at this point. There has been some attempt to look at this, and I only highlight this one paper, which came out of the UK in the Lancet Oncology recently, which did a modeling study in terms of the impact of a 3-week delay on 10-year survival. You can see that bladder and kidney had the largest degree of negative impact due to a 3-month delay. However, I'd like to believe that because of our ability to triage patients, to defer treatment and open up resources for those who did need treatment as urgently as possible, that these numbers hopefully are overblown, but only time will tell. So at this point, as we look at this map, of course, sadly, these numbers are rising, and if you look on the internet or read a newspaper, you'll see terrible headlines like this. So it's certainly possible that we'll need to go back and triage our patients at some point before this pandemic is over. But in conclusion, delaying GU cancer surgery in the time of COVID-19, I want to emphasize that beyond just the need to free up resources, we have had to reconsider surgery for some of our patients with the knowledge that COVID-19 has substantial surgical morbidity and mortality, and it can impact the healthcare professionals as well. As soon as several people have to go out on quarantine, that's just reducing the staff and the ability for us to care for our patients. But I don't want to leave this on a negative note, really. I think that GU cancers are among the most feasible to care for in this climate. We do have a wide variety of presentations for GU cancers. For many, such as low-risk prostate cancer, small renal masses, non-muscle invasive bladder cancer, we can safely defer surgery without any apparent or expected negative impact on our patient's health. And for those who need more care, we also have a multidisciplinary approach to care. And so for many of our patients who perhaps can't get surgery right away, there are additional approaches that we can employ to keep them as healthy as possible. But no matter how you look at it, right now we have shifted for the foreseeable future to doing battle on two fronts. We continue to have an estimated 1.8 million cases of cancer diagnoses in 2020, which kind of is almost 5,000 cases per day. But unlike in the past, we've had to deal with caring for these patients in the setting of COVID-19, and certainly for surgery, we have to deal with managing our patients, are triaging the surgeries that need to be done, deferring those that can be deferred, and then managing all the risks that come associated with this. Thank you very much for your attention.
Dr. Chang, that was super interesting. Something that I would love to hear a little bit more about was the comment you raised about capacity and infrastructure around physician and trainee wellness in the context of this. I mean, that's certainly been brought more and more to the forefront as we think about the stressors that this pandemic places on healthcare providers. So could you tell us a little bit more about your institution's approach to that problem?
Yeah, I mean, I think this is an evolving situation. I think some of the more obvious issues are if somebody, like as I mentioned, if for example, I am exposed to someone, I go on quarantine for 2 weeks, my cases for the next couple of weeks, and I operate typically 3 times a week, all those cases, I'm not sure what's going to happen to them. But this whole issue has been a tremendous strain on the healthcare system, on the mental health of our staff. As I'm sure in your institution, it may be the same. We all have to have these attestations before we come into the hospital. We all come through different entrances now than before. The day-to-day is all different. And so there are routine updates that we get essentially on a daily basis. We've had a COVID-19 outbreak within our hospital. We've had a widespread availability for services to help with burnout, but also actually one of the silver linings is it has made it very easy for any and all of us here within the hospital to get tested, asymptomatic or not. So that actually alleviates some degree of stress. But I don't know that there is one thing that we're doing here at our hospital in particular that's helping, but simply the recognition that COVID-19 has on the mental health of all healthcare professionals. I think that's the biggest first step in the process. I don't know if you at UCSF or at Penn, there are anything unique that you guys are doing to help with that aspect of things or not.
I think I agree with you that there's certainly an acknowledgement of the additional stress associated with this pretty exceptional time. And I think there are campaigns to ensure healthcare providers recognize what resources are available within our own environment. That doesn't change the fact that this is stressful. And, it's stressful for us. And then we're navigating patients who may have additional stress and we're trying to be supportive for them. And I think, and then there's, of course, a lot of providers across different health systems are experiencing pay cuts, salary freezes, furlough days, all sorts of changes to their own, economic stability, and that is also to be determined in terms of the depth of that. So I think there certainly is a role for improving that, and part of that could be, done within each institution. But I think there's an opportunity to not have siloed efforts, but for there to be more of a national strategy across health systems that acknowledge workforce distress in order to ensure that the workforce is strong and taken care of in order to take care of the population's greatest at need right now.
Yeah, I could not agree more.
Dr. Chang, it was really fascinating. I think one other thought that came into my mind is, just like you have this risk-based strategy for handling definitive treatment for urologic malignancies, what is your sense about the potential backlog or how to approach patients who are being planned for sort of diagnostic evaluations for GU malignancies? So for example, a high PSA, but no diagnosis yet of prostate cancer, or those patients who are having hematuria who may typically undergo a cystoscopy or some other evaluation.
Yeah, I focused on the changes in the operating room, but we've had similar changes in the clinic, both the social distancing need and the need to maintain safety among our staff. We've scaled back many of our services, including the biopsies, the cystoscopies. What we've done is we've tried to rearrange the clinics to accommodate more patients in sort of a different manner. We used to consolidate all of our biopsies on for certain biopsies on certain days, but now they are more widely available, albeit fewer biopsies per day, for example. And cystoscopies, we were my colleagues and I used to just do cystoscopies, but now we've had cysto clinics, if you will, so that one practitioner would be just doing cystoscopies all day, so that and our patients would be referred to one another in order to get them in for that procedure. So somewhat the same idea of not siloing ourselves in terms of how to care for it, but even within our group, we were working more as a group to get our patients in a more expeditious manner. Maybe it's not my patient is not being evaluated by me with the cysto or the biopsy, but the patient's being cared for by the larger group. And I think that we've also shared, within our community in the Boston area, shortages for things like BCG. There have been urology, contacts from other institutions to see if they can get their patients over to us if we have more supplies. I think we are seeing a more collective group effort, but in order to combat this hopefully once in a lifetime pandemic, the situation is ridiculous.
Yeah, really fascinating, and it's just amazing the sort of the logistics and coordination that has to go into all of it.
But I think that if there's any positive we can come out of this is really understanding better how to work together, not just as a multidisciplinary, which is what we usually think about, medical oncology, radiation oncology, surgical oncology, but how we can work with our staff to create a better schedule for our patients, and how we can really incorporate telemedicine so that patients don't really need to come in that much. I think I'd like to be positive about how the lessons that we learn about this can be rolled out in the future for better care of our patients.
I tend to agree with you, Dr. Chang, that I think that, let's end on a note of optimism, which is that perhaps the different changes that your institution has thoughtfully implemented, and I think many institutions across the country could allow for us to continuously rethink the burdens we place on patients as they receive standard of care or care in the context of a clinical trial. Ask ourselves, do they really need to present to a health facility in order to achieve good safety monitoring or to be assessed? Can we really ensure that they can be taken care of while also minimizing burdens of travel and additional cost? And I think that this exceptional, challenging time may allow us to potentially create durable change in our approach to delivering healthcare.
It's really well said. Couldn't have said it better.
Agreed.
So maybe I think that concludes the talks for today. So thank you to all the participants and to our patient advocate. And I think we're happy to answer any questions during the chat.